The following video is a case presentation on silicone oil retention suture technique for uveitic hypertonous eyes. Ocular hypertony is defined as intraocular pressure less than 5 mm of mercury. There are multiple causes leading to ocular hypertony, most commonly being ocular trauma, chronic uveitis, and intraocular surgeries. Ocular hypertony poses a challenge both in terms of medical and surgical management. There are multiple studies which quote that if left unattended, ocular hypertony can lead to a number of complications like choroidal detachment, hypertonic maculopathy, hypertonic keratopathy, optic disc edema, ultimately leading to progressive visual loss and phthisis. The last image showing a prosthetic eye. The surgical management of ocular hypertony includes pars plana membrane cleaning with release of traction over the ciliary processes and silicone oil injection for tamponade. The main postoperative concern in aphakic eyes is anterior migration of oil, which ultimately leads to corneal decompensation. So what can be done? We know the answer. Silicone oil retention sutures are placed 1 mm posterior to the limbus and act as a barrier between silicone oil and the anterior chamber, preventing its contact with the cornea. Much like the line of control, our soldiers protecting our country from intruders. How does it work? The surface tension of the silicone oil aqueous interface is high, and hence the silicone oil maintains its integrity as a spherical shape, and the sutures work as a barrier. A 57-year-old female patient presented to the OPD with visual acuity in the right eye being hand movement and intraocular pressure of 8 mm of mercury. She was diagnosed with idiopathic chronic uveitis with chronic hypertony and complicated cataract. B-scan showed thickened coats with disc edema. The patient underwent cataract surgery under cover of low-dose oral steroids. The UBM showed thickened ciliary body with blunted ciliary processes with membranes covering the surface. The posterior capsule is plastered to the iris with bulging of the vitreous phase, as is also seen on the anterior segment OCT. Hence, we decided to go ahead with the surgery. 3 25-gauge pars plana sclerotomies were made. Core vitrectomy was done. The posterior capsule attached to the iris is cleared and base shaving is completed by peripheral indentation. As it is a non-dilating pupil, 4 iris hooks are placed. The most crucial step is the dissection of membranes over the ciliary body. Extensive external indentation of the pars plana region allows adequate visualization of the ciliary body. The membranes are released with intraocular forceps without causing undue pulling, and then cut with low vacuum high cut rate settings. This procedure is repeated at all clock hours. Once completed, the iris hooks are removed. Limited conjunctival peritomy is done at 3 o'clock, 9 o'clock, 12 o'clock and 6 o'clock. Four partial thickness scleral incisions are made tangentially at 3 o'clock, 9 o'clock, 6 and 12 o'clock, 1 mm posterior to the limbus. 9-0 polypropylene straight end suture is passed through the scleral grooves from 330 to 830 and brought out on the opposite side with the help of a 26-gauge bent needle. The next suture is passed from 2:30 to 9:30. The same procedure is repeated vertically with sutures passed from 6:30 to 11:30 first, the final suture is then passed from 5:30 to 12:30. The sutures are tied and the knots are buried. Inferior peripheral iridotomy is done at 6 o'clock with the help of a cutter. Fluid air exchange is done. 5000 centistop oil is injected. The flute is used to remove the residual air bubble and the silicone oil is filled up to the level of the sutures. The ports are removed and sutured with 80 Vicryl. Post-operatively, the patient is doing well with visual acuity of 6/30 in the right eye, with intraocular pressure maintained more than 8 mm of mercury. Anterior segment shows well-centered polypropylene sutures preventing the forward movement of the silicone oil. The wide field fundus imaging shows well-settled retina with sutures in place. Posterior segment OCT shows few choroidal undulations with well-settled retina and mild macular edema. There are multiple patterns of silicone oil retaining sutures, namely triangular, star pattern, H pattern, trapezoid and square pattern, which is selected based on the surgeon's convenience. The pros of this procedure are: it is cost effective with no added trauma, failure does not alter the course of treatment. The cons include: it is less effective in very severe cases of hypertony, technically challenging for beginners, and newer techniques available are aniridia IOLs and vitreous bag implants. To conclude, silicone oil retaining sutures remain one of the most effective ways to prevent oil migration to the anterior chamber in aphakic eyes, and hence prevents cornea-related complications. Designs can be modified based on the surgeon's preferences. Thank you.